Hello and welcome to today's Talking Point presentation. I'd like to first begin by acknowledging the traditional owners of the land on which we meet today and pay my respects to their elders past and present and extend that respect to Aboriginal and Torres Strait Islander people listening today or in the future. My name is Vic Manning. I'm the Head of Research and Workforce Development here at Turning Point, and I'll be facilitating today's Talking Point, nicotine e-cigarettes for smoking cessation following discharge from smoke-free inpatient AOD withdrawal services, presented by Professor Billie Bonevski. Talking Point is a regular series of publicly available lectures that aim to inspire, inform, and challenge notions of what we know about addiction and its impact across society. We like our webinars to be as interactive as possible, so please do ask questions via the Q&A function for online attendees. The questions will be collated and answered by Billie at the end of the presentation, and our webinars are recorded and will be made available later on the Turning Point website. So I'd now like to introduce Professor Billie Bonevski, who is the Dean in Research and Director of the Flinders Health and Medical Research Institute, and Matthew Flinders Professor of Public Health at the College of Medicine and Public Health at Flinders University. She's a behavioural scientist and she's recognised internationally for her research examining ways to assist people in priority population groups to reduce tobacco smoking. And here at Turning Point and some other AOD withdrawal services in Melbourne, we've had the real pleasure of collaborating with Billie on a couple of her studies, which you'll be hearing about today. So over to you, Billie.
Oh, thank you so much, Victoria, and I'm thrilled to be presenting with you today. So I hope this is of interest. And before I start, and I've just had a frozen screen, I also would like to acknowledge that I'm on the traditional lands of the Kaurna people, and Flinders University has campuses across the entire Central Corridor. And I acknowledge the traditional custodians of the lands that all of our campuses sit on, and I pay my respects to elders past and present, and any Aboriginal and Torres Strait Islander colleagues who might be on this webinar today. So I'm going to try to cover a lot in a little bit of time. So I'm really happy to take questions, as Victoria outlined after the presentation, but I'll run through, I'll actually spend a good amount of time on the background, because I think this trial that we call the NEAT trial needs some explaining as to how we got there. So I'll go over smoking prevalence and burden, particularly for people who might be using alcohol and other drugs. A little bit of background on smoking cessation strategies and evidence-based methods, and then looking at e-cigarettes for smoking cessation, so as a strategy to help people quit smoking. And then I'll go through very quickly the NEAT trial methods and their results and some key take-home messages in my conclusions. So I'll start by explaining the terrible burden that tobacco has on our health system. It causes over 21,000 deaths in Australia in any given year, and it is an immense burden to our health system, with 1.7 million hospital separations annually, and massive financial costs, so health related, social costs as well. $136.9 billion in direct and indirect costs due to tobacco use. As far as cardiovascular disease is concerned, it doubles the risk of developing most types of cardiovascular disease, and mortality from cardiovascular disease is almost tripled in people who smoke versus those who don't. It's a cause of 15 different types of cancers. And for Aboriginal and Torres Strait Islander people, it's the cause of half of all deaths for people over 45, which is where most of the deaths sit. The prevalence of smoking use or tobacco use amongst people with drug and alcohol diagnoses or mental health illness is very high compared to the general population. So this graph here, you'll see the red dotted line, which is an indicator of the general population. And I've got it here as 11%, but it's actually, sort of hovering just under 10% now. So in the general population, it's incrementally over the years just fallen, but very high amongst people who use drugs, who use alcohol, who might have hepatitis C virus, and then a range of different mental health disorders. As you can see there, it's at least double the rate of general population smoking. So the burden is immense. And the National Mental Health Commission, I'm just giving a webinar.
Okay, sorry.
The National Mental Health Commission released a report referring to the impact of tobacco smoking on people with mental health disorders as a national disgrace, because what it leads to is a disproportionate high level of mortality and morbidity due to tobacco-related diseases like cancer, cardiovascular disease, and the respiratory diseases. And it also leads to a 10 to 20 year life expectancy gap in these populations. Look, there's little data, and I've just pulled out some more local Australian where I can find it, and this is Louise Degenhardt's data on the burden of tobacco amongst opiate agonist treatment clients, and you can see there that the burden that tobacco causes is immense amongst people in treatment, and it's very similar internationally as well. So this is a global issue. Tobacco use amongst people who use other substances is a global crisis. Now, there's other impacts other than those direct morbidity and mortality impacts due to smoking. So there are a range of studies that show that for these population groups, smoking is associated with more psychiatric symptoms, more hospitalizations, higher doses of psychiatric medications. There's an element of financial stress because tobacco cigarettes are costing so much. And with smoking being really denormalized in society and legislation that has been introduced over 20 years, which has been hugely successful in reducing smoking rates, but making smoke-free areas more common as far as our environments are concerned. It means people who smoke are increasingly marginalised and in the fringes as to, they don't feel like they can be part of society in most environments that are smoke-free. Now, if you help someone quit smoking, you will improve their physical health, you will improve their quality of life, you will, there's reports showing decreased anxiety, decreased depression, stress, alcohol use, and there's financial savings and quality of life benefits. There's even studies that have shown that once people quit smoking, they're much happier as well. Now, there has been a little bit of work also done that shows that people who are in drug and alcohol treatment are interested in quitting. So this is one, Pete Kelly in Wollongong conducted a survey and found that most people had tried quitting in the past or were thinking about quitting now. And, you know, another result of this survey was that they use very few smoking cessation aids. So they tend to go cold turkey, which is one of the least effective methods for quitting smoking. So given the interest in quitting and multiple quitting attempts, why do smoking rates continue to be so high? And again, there's been an exploration of, you know, what some of the barriers to quitting might be, particularly amongst these populations, priority populations of people with other drug use or mental health problems, or you know, some disadvantaged groups as well. And what some of that research shows, that compared to the general population, people who smoke in those populations tend to be more heavily nicotine dependent. So they're smoking more cigarettes a day, and that's often because they started smoking at a much younger age. And so when they start to think about quitting, they're very nicotine dependent, and then they experience more severe withdrawal symptoms with those quit attempts. And if they're not using cessation aids, that makes overcoming the withdrawal symptoms just so much harder. There is coexisting alcohol and other substance use reinforcement of the rush or the buzz that people feel when they're using nicotine as well. And there are also feelings, particularly for people who have mental health symptoms, that the smoking alleviates some of those mental health symptoms. Now, there's also the broader social and environmental context of smoking for these population groups. It might be a case of almost everybody that they know, their peers, family members smoke, so perhaps smoking's permitted in their household, and perhaps they have social gatherings, and you know, smoking is a social element of their life, and so quitting becomes very difficult if people around you are still smoking. We've found that, you know, unfortunately, there are reports of lower self-efficacy for quitting attempts, and so they don't believe that they will be successful at quitting when they do attempt it. And there has been some research showing that, and this is ironic as well, that financial stress reduces an individual's success at quitting, but cigarettes prices keep going up, so their financial stress keeps going up, but because they're financially stressed, they're having less success at quitting. So and then finally, this is an important one, there's good research that shows that they receive less health provider advice to quit smoking as well. So it's really important within the health service context as well to address people's smoking. So what works? Well, we have a world of data, very, very rich evidence base around the effective smoking cessation strategies. And we know that at any given time in the population, about 3% of the population of people who smoke will just quit. We'll just go cold turkey, you know, not using any aids at all. Now we can improve that success by just brief advice of 5 minutes or less, you know, a couple of minutes of advice from a healthcare provider can significantly improve a person's success at quitting. Now, if they get more involved counselling, say they engage in the quit line, then that increases the chances of success as well. Of course, using nicotine replacement therapy, or NRT, is very, very important for addressing those withdrawal symptoms that they might be experiencing. But clinical best practice is the combination of both behavioural support to quit as well as pharmacotherapy like nicotine replacement therapy. Varenicline, or commonly known as Champix, is a prescription medication, and it is the most effective smoking cessation support that we can provide to people who smoke. And there's some good data there comparing varenicline with nicotine replacement therapy. Of course, both are good. But some people don't tolerate varenicline very well, but it's safe and it's effective, and that's another pharmacotherapy that is sometimes used. It's not favoured by people who smoke, though. And so, we have this rich evidence base of smoking cessation strategies that work. And as a result, we have clinical guidelines that state that we should be providing people who smoke, who come into our services for care, we should be providing them with support to quit. And we know what works. We know that combining some sort of pharmacotherapy, whether it's varenicline or nicotine replacement therapy, with behavioural counselling, is giving that person the best possible opportunity to stop smoking. And there have been studies looking at smoking cessation strategies for people with either alcohol or other drug use. And there's a list of these studies here. Alcohol and other drug use, as well as people with mental illness. And these strategies that are effective for the general population can be effective for people with alcohol and other drug use, or mental illness, and often those things are co-occurring, as we all know. But what the literature has also found is that beyond the term of a clinical trial, as most of these studies are, that people revert back to smoking, or they relapse back to smoking. So it's very important to provide ongoing support in the longer term. So relapse rates are high, and some of those mitigating factors might have to do with the alcohol or other drug use dependence, so smoking related cues and triggers when using other substances, the lack of cessation support that I indicated earlier, and the social environment, and the heavy nicotine dependence levels, and of course underutilization of these existing smoking cessation aids like nicotine and replacement therapy. But addressing that high relapse to smoking rate amongst people with alcohol and other drug use is very important in order to help them remain smoke-free once they've made that quit attempt. So people are not using readily available smoking cessation aids like varenicline and nicotine replacement therapy. And over the last 10 years or more, e-cigarettes have entered the scene, and it's also commonly known as vaping. And these are becoming increasingly common in our society. And there is a good body of literature now suggesting that they are effective in helping people quit, and that they may be less harmful than your traditional cigarettes. The combustible element of cigarette smoking, the burning of the tobacco and all the additional ingredients, what make tobacco cigarettes so dangerous. And it looks like vaping and e-cigarettes are preferred by users. People like to vape, they like to use e-cigarettes, and we thought it might be worth exploring whether e-cigarettes might help people with other drug and alcohol use to quit tobacco cigarettes, and particularly for longer periods of time. And I'm sure you know what vapes and e-cigarettes look like. They are electronic devices that have a heating element inside them, and it's usually liquid nicotine, sometimes it's salt, and a couple of other ingredients, and then the heating causes a vapor, and this is why it's called vaping. There's no burning, there's no smoke involved. It is vapor or steam that is released. And the use of e-cigarettes for smoking cessation is now included as a second line therapy in the Royal Australian College of General Practice guidelines. And they are available in Australia through either a doctor's prescription for smoking cessation or through pharmacists. And there needs to be a discussion with the pharmacist regarding the use of the e-cigarettes for smoking cessation. And you can see there that it's for people aged 18 and over. They are much more restrictive for people under 18. Non-pharmacy retailers are prohibited from selling vapes and e-cigarettes, and there are restrictions in Australia around flavours, and we do also have restrictions around advertising and promotion. And many of the smoke-free environment legislation in Australia at the moment includes vaping and use of e-cigarettes. So what's the evidence base regarding their effectiveness for smoking cessation? It's actually quite strong now, and there is an ongoing Cochrane living systematic review. There's the details there if anybody is interested in reading further. But I'll just summarise the review at the moment's got 78 studies included. 40 of them are randomized controlled trials, which include over 22,000 participants in a number of countries. And if you compare nicotine e-cigarettes versus nicotine replacement therapy, there's high certainty evidence that e-cigarettes with nicotine in them are more effective at helping people quit smoking than nicotine replacement therapy, and stay quit at 6 months follow-up. So that's very strong evidence. But most, or actually all of these studies were conducted with general populations. They have not been conducted with people with other drug use. There's also some general population observational studies. So in the UK and in the US, there's been a 10 to 15% increase in smoking cessation since they've made e-cigarettes more readily available. People who vape more frequently are more likely to quit smoking than people who don't vape. These are all observational survey results, and people who smoke are more likely to use nicotine vaping products in quit attempts than any other product. So there is a preference to use vapes over nicotine replacement therapy or varenicline or other smoking cessation supports. Studies have found that there's greater success than other cessation aids when used in stop smoking services in the UK. And there's been some simulation analyses done that show that there is increasing smoking cessation, that if we increase smoking cessation, vaping will avoid large numbers of premature deaths over time, because smoking is the most dangerous thing that we can do as a society. And there is an inverse relationship between the sales in vapes and the sales in tobacco cigarettes. So as vape sales go up, the cigarette sales go down. So why might they be more effective than nicotine replacement therapy? One of the reasons is because they more closely mimic the effect of tobacco cigarettes for people. So the blue line in this graph is the nicotine hit that people get when they light up a cigarette. And then all these other coloured lines are different types of vaping products, nicotine vaping products. And you can see that the pattern of effect is very similar, and that the intensity of the effect comes very close to that of a tobacco cigarette. And nicotine replacement therapy just really doesn't have the slow release is a very low dose over a longer period of time, and the oral forms like a lozenge are very low doses, so you don't get the same intensity as vapes. And some of the other reasons why they might be more effective than nicotine replacement therapies, because they address those cravings that people get for cigarettes and a hit. There's the behavioural social element, so you can still go to your party with friends who might be, or family members who might be smoking, and you can have a vape and you can participate in that. They're much less costly than nicotine replacement therapy and indeed, of course, cigarettes. Although restricted in Australia, people still do seem to find ways to purchase, a variety of different flavours, and we still have a lot of surveys showing that people perceive them as being a lot less harmful than cigarette smoking. So are they less harmful? And the weight of evidence seems to suggest that they are much less harmful, but they're not entirely harmless. So there's some very good and big reviews of the evidence that has been conducted. There are still a lot of cell-based work or animal-based work that we're relying on for this evidence, but what it seems to indicate is that nicotine vaping product use is likely to be much less harmful than continued smoking. And this is one example where we have, the conclusions of the UK 2022 report that in the short and medium term, vaping poses a small fraction of the risk of smoking, but it's not entirely risk-free, particularly for people who have never smoked. You don't want them to start vaping. So we are very focused on vaping for smoking cessation, not vaping for fun. And evidence, though, is limited to short and medium term effects because they have been on the market for such a short period of time. We don't have those 20, 30, 40-year results to really fill us with confidence that they are safe as far as the biggest killers like cardiovascular disease and cancer that are slow developing diseases are concerned. So based on all of that evidence, we thought, and the fact that there's a gap in the literature, there's a good amount of literature showing that e-cigarettes are effective for smoking cessation and more effective than the conventional and readily available nicotine replacement therapy. But none had been done with people who are in drug and alcohol treatment or who might be using other substances. So we thought that we would look at this question in particular. And after discussing this idea with the wonderful people at Turning Point, including Victoria and Dan Lubman, it seemed that a lot of drug and alcohol treatment services are now smoke-free, so people get support to stay smoke-free while they're in treatment, but then as soon as they walk out the door, they'll likely light up a cigarette again and go back to smoking. So we decided to focus on that period of discharge from treatment so we could make the most of the fact that they had been smoke-free for anywhere from a few days to a few weeks, and then provide them with as much support as possible as discharge and immediately post-discharge to see if we could try to keep them smoke-free for as long as possible. And we conducted a small pilot trial in one of the Turning Point sites in Melbourne. You can see there we recruited 100 people and randomized them to either receive what is current best practice, or certainly at the time best practice, and that's nicotine replacement therapy with some quitline behavioural support, and compare that with this new method of smoking cessation, which is nicotine vaping products. And we followed people up at 6 weeks and 12 weeks. We provided them with a pack at discharge that contained either of those two products, either nicotine replacement therapy or the nicotine vaping products, and everybody got the quitline support. And we were really looking at exploring whether it was feasible to do this, whether people would take up the offer of smoking cessation support regardless of the type, and some indication of the effectiveness at 12 weeks follow-up. And what we found in summary with this pilot study was that the vaping products were more acceptable and feasible than the nicotine replacement therapy. People sort of chopped and changed and tried different types of nicotine replacement therapy, whereas they were really happy to take up the offer of an e-cigarette and be trained in how it was used and keep using that longer term. It was very acceptable. Nicotine vaping products and the nicotine replacement therapies had similar abstinence outcomes and smoking reduction outcomes at 6 and 12 weeks follow-up. So we thought that was interesting. And also there were no differences in safety outcomes, so as far as adverse events. And so these results led us to the development of the much larger NEAT trial, because we thought, well, it's feasible. We can implement this system of providing some sort of smoking cessation support at discharge from drug and alcohol treatment. And we didn't have the sample size. We weren't powered in this small pilot to properly examine effectiveness. So we wanted to look specifically at the effectiveness and see whether the results that we got of similar abstinence rates, whether with a properly powered trial, we would see differences in nicotine vaping products and nicotine replacement therapies for smoking cessation in this population. So basically the aim of the NEAT trial was to examine the effectiveness of interventions consisting of either nicotine vaping products plus quitline or nicotine replacement therapies plus quitline at continuous abstinence at 9 months follow-up. So that's, at least 7 months of staying quit when we followed them up 9 months following discharge from a smoke-free residential withdrawal treatment service. And the paper's now been published, and you can get all the details from that paper. I won't go through the details here, and I really do apologise for this detailed slide. But as you can see there, we enrolled and randomised 363 people who were leaving residential treatment. And then if we move down at 3-month follow-up, so immediately following treatment, we were able to follow up 129 in those in the nicotine replacement therapy, and then it was 115 at 9 months, the longer follow-up, which was our primary time point. And for those receiving the electronic cigarettes, at 3 months, we followed up 125 and then 114 at 9 months. But our primary analysis was intention to treat analysis. We took the conservative approach of assuming those lost at follow-up were continuing smokers. And we conducted Bayesian analyses, and this is a summary of the results that we found at our primary endpoint of 9 months follow-up. So they had been either abstinent or not for 7 months. And you can see here in the first row, it shows the intention to treat results of all 363 participants. The proportion of people quit in the e-cigarette group was around 10%, and the proportion of people quit in the nicotine replacement therapy group was also about 10%. So there were no differences. There were no statistically or clinically significant differences. So very similar to our pilot trial results. And even if you only took the data from those participants who finished the study and the follow-ups, so complete case analysis, about 17% of the e-cigarette intervention group quit, and about 16% of those in the nicotine replacement therapy quit. Now, this was a superiority trial, so we had hypothesized that those in the e-cigarette group would have higher cessation rates than those in the nicotine replacement therapy, because they're the results of the Cochrane review trials. And what our results suggest that both of these supports for smoking cessation are equally, did equally well, are equally effective. Now, this is a population group where smoking cessation is generally close to zero, and we got around 10%. So, while there were no differences between the groups, we were quite happy to see that there were good proportions of participants who did achieve abstinence and stayed abstinent at 9 months, which, like I said, most other trials find, the cessation rates are close to zero at that point. Importantly, because the safety question always comes up when e-cigarettes are discussed, there were no differences in adverse events, or certainly not in serious adverse events. Either the one death in the e-cigarette group was an accidental death. It had nothing to do with the product under investigation. So the key conclusions and take-home messages that I want to communicate is that smoking rates are just still too high amongst people who are using other drugs than alcohol, and they haven't really changed in many years. And as a result, tobacco-caused diseases and other tobacco-caused issues are a great burden on this population group. Evidence-based smoking cessation strategies are available. However, they're not being routinely delivered in practice, and perhaps related to that, they're not being used by people who smoke, and people who are clients of drug and alcohol treatment services deserve to be offered all the available smoking cessation supports that we have at every visit. So that might be a vape, that might be an e-cigarette, or it might be another option if that's what the clients prefer. We should value and respect patient preferences, considering the evidence base in showing that e-cigarettes are effective and are much less harmful. The worst thing is for that person to continue smoking. So that is the worst case scenario, and that's what we want to avoid. And I think that's it. Thank you very much.
Thank you, Billie. That was amazing. You did such a fantastic job of summarising, all the evidence and the strong rationale for why we really want to offer smoking cessation to people seeking AOD treatment, and then presenting the results from those studies. And yeah, it's just it's really good to see more evidence coming forward that quitting cigarettes is associated with higher rates of reducing their primary drug of concern. We had I don't know if you saw the study published in, I think it was JAMA Psychiatry, the PATH study, which is a representative general population survey in the US, and they found that people who'd quit smoking had a 42% increased likelihood of quitting the alcohol or drug problem they had. And years ago we ran the patient pathway study and found that people who quit, which was only 7% after initiating a treatment episode, but of those who did quit, it was 30% increased likelihood of them having significantly reduced their alcohol drug use. So it's really, the evidence is building that we really should, as clinicians, we should be encouraging people to do that. But given the sort of barriers, the additional barriers that clients may face, what would you sort of advise to clinicians in trying to sort of encourage, to quit?
Yeah. Look, I think clinicians should, use all the supports that they can find. So all clinicians need to do really is provide that brief advice. So to trigger the idea. Then there's referral pathways, and then there's pharmacotherapies as well. The clinical guidelines recommend varenicline prescription. Not everybody likes varenicline, so people can try it, and if they don't like it, perhaps nicotine replacement therapy, perhaps e-cigarettes. So those pharmacotherapies are very important, and it's very important that people have opportunity to try different things. And I think one thing that clinicians often face is they might try one type of pharmacotherapy with a client, doesn't like it. They might get a rash if it's a patch, or sore throat if it's, something else, gum or lozenge or something. So keep trying so that, the client or the person who's you're helping quit might land on what works for them. And then, the quit line is this incredible resource that is very underutilized and can take a lot of that behavioural counselling work off the clinician. But can also support the clinician if need be. So some clients might want, they have a relationship, say it's a drug and alcohol counsellor or their doctor, and so those clinicians can also lean on the quit line to support them to provide the best possible support to their clients. And the other thing is social support. So there's been quite a lot of work done suggesting that if your client can identify someone, just a family member or a friend or someone that they trust, that if they're experiencing a craving or they're thinking that they might relapse back to smoking, someone that they can quickly get in touch with. That seems to be very important in maintaining a quit attempt and maintaining abstinence. So helping your client identify that key person, that support person or a buddy, for quitting.
Yeah, it's really important. And if they are interested, you share some research that said there is a preference for using e-cigarettes. How easy is it for people to access that? If they go to their GP, are they going to be told, "Oh, try an RT," or see the pharmacist? How accessible is it?
Yeah, it's not particularly easy. And it's designed to be not particularly easy. But I think that as a clinician, you can provide a letter, perhaps a letter of referral. So there's not a lot of GPs who feel comfortable prescribing e-cigarettes for smoking cessation. They will often talk through the other TGA approved pharmacotherapies. Now, if the person's tried everything else and it hasn't worked for them, then perhaps reluctantly they might. But people can get e-cigarettes from pharmacies without a prescription, so they don't need to go to their GP. They do need to have a conversation with the pharmacist, and if you're a clinician for someone like that, say within the drug and alcohol treatment setting, then maybe you can provide a letter or some sort of evidence to support that client in having that conversation with the pharmacist, and that indicates that it is genuinely for smoking cessation, and they have tried everything else, and we really need to try this as well.
That's a great tip. Thank you. So a couple of questions we've got. One is around how confident can we be that tobacco sales are really going down with vapes going up? And there's also so much, on the black market, cigarettes are sold, I certainly see a certain brand everywhere. It's how do we know if those rates are really dropping?
As far as tobacco sales rates are concerned, so cigarette sale rates
Cigarettes,
are
yeah.
concerned, the data is very clear. They are going down, but yes, absolutely, the illicit market's going up, and
Mhm.
we don't have data on that. I know that there are people working on trying to collect that data on the illicit market to give us a better idea. Look, in terms of smoking rates going down, the data that we have is fairly reliable, and we've been collecting it for,
Yeah.
50 years plus. So it is going down, but it is going down a little bit slower now, but it continues to go down. And we need to be confident in that data because that's what we have.
Yeah.
Yeah.
So it's sort of household data, household survey data,
That's that's right.
yeah,
Yeah.
even though we can't track based on sales, we know consistent reporting from, say, the AIHW
That's right.
surveys. Yeah, yeah, cool.
That's right. Yeah. And we can track sales, but only legal commercial sales. We can't track the illicit trade. Yeah.
Yeah. So there's another question around whether we know what the sort of longer term, do we know how many people become long-term vapors
Yeah.
after smoking cessation? They'll probably be dependent on nicotine, but obviously taking it in a slightly less harmful way. And is it important? Yeah, should that be pointed out when
Yeah.
statistics are cited? Yeah.
Yeah, yeah, look, people do. And so they might switch rather than stop.
Mm.
Right. So that's the thing. And I know in the UK they actually had a campaign that was called Swap. And it was all about getting people off tobacco cigarettes and getting them on e-cigarettes.
Mhm.
Um, I think the biggest concern is young people. We don't
Yeah.
want young people who haven't smoked taking up vaping. I think that if you're 50, 60 years old and you've been smoking for 30, 40 years and you switch across to a much less harmful product,
Yeah.
um, you know, sure, if you want to quit, we've got strategies, similar sort of nicotine dependent strategies to help people for quitting vaping. But some people enjoy it and continue it on. So, um, they're much, much less harmful.
Yeah. We've got a few questions coming in, so I might whiz through these so we can finish up just before 2. In terms of the flavouring, is there any evidence as to which flavours are most harmful?
Oh, oh, that's a really interesting question. And I don't know whether I have the answer to that. And it depends whether the question, whether you're referring to flavors as what gets people hooked more, and so that behavioral
All the
harmful,
chemicals that are,
or,
yeah,
or the
yeah,
chemicals. Yeah, yeah. So no, look, I don't know. I'm not aware of that literature and whether different flavors are. I think that the market is so unregulated,
yeah.
right? So
You
that
don't
so
really know what
that's
you're getting.
you don't know what you're getting, and it's product to product
Yeah,
rather than flavor to flavor.
yeah. Okay.
So there are restrictions on the flavors that pharmacists can
Yeah,
sell, like that, it's basically no flavor, or I think one of the flavors they're allowed to sell is menthol and tobacco flavored, like they're not strawberry cheesecake,
yeah,
passion fruit pop, sort of flavors that young people tend to want, and that's what we don't want. We don't want the flavors that attract young people.
And a couple of questions. People have observed it being more difficult to quit vapes and cigarettes, and the fact that you're sort of puffing, you're vaping throughout the day or several times rather than just finishing a cigarette and maybe not smoking for a few hours. Does that make it more addictive and harder to quit?
Yeah, I think, and I think that's a real concern with young people as well, in that, you've got these, like I said, strawberry cheesecake flavors, and they're puffing away and they become nicotine dependent quickly, and heavily nicotine dependent. So absolutely, that's why we want to keep them away from young people. I have seen reports of adults, sort of using e-cigarettes to quit smoking. Fantastic. But now I'm vaping a lot. So the telephone quit lines are adapting, and they're providing support for adults who now want to quit vaping, which is good.
Yeah. And there's a question around acceptance and commitment therapy. Do you know if there's been any studies looking at that particular psychological approach for smoking cessation? It says, I would have thought with the price of cigarettes in Australia, this would be an incentive to quit. How much are cigarettes now for a packet? We're talking $50, is it?
Yeah, I think they're between 40 and 50 for a pack. So if you're a pack a day smoker, that's very expensive. Look, again, I'm not too familiar specifically with acceptance and commitment therapy. There is a mountain of literature on different counseling types. And cognitive behavior therapy and motivational interviewing, and so I would think that there is some level of evidence for that type as well.
Yeah. But it's really clear from everything you shared today, it's about, presenting the options. And, we're really encouraged to see 3 times as many people quit with the support of either e-cigarettes or NRT and counselling, than we would typically see in a population that most need to. So yeah, it's been great having you, Billie, and you're happy to share the slides. So we will.
Oh yeah, sure. Yeah.
Questions about that. But yeah, it's been fantastic. Thank you so much.
Oh, thank you. Thank you. I hope it was useful for someone.
It was, most definitely. And I think we have a talking point again next week on recovery capital. So we're squeezing one more in, I think before the end of the year. And then, yeah, we'll see you guys at the next one. Thank you.